Welcome and thank you for joining. My name is Beatrice Patches and I am the Health Educator for Community Health at Atlantic Health System. Today's webinar, Keeping the Plumbing Clean, is presented by Cindy Codispoti, Doctor of Osteopathic Medicine and Fellow of American College of Cardiology, Atlantic Medical Group Cardiology in Hackettstown and Sparta. Before we begin, I have a few announcements. This webinar is being recorded and will be shared in its entirety on our website. All participants are muted. If you have a question, please use the Q&A for questions or chat for comments. We will try to get through all questions at the end of the presentation. Our Healthy Aging program at Atlantic Health System is a great resource to assist or a loved one with obtaining many helpful services and information on topics of interest. For a comprehensive list of services, you can visit atlantichealth.org/senior services. I am now going to turn it over to Dr. Codispoti.
Thank you so much. Just a quick check that you can see my screen, my presentation.
Yes.
Okay, excellent. Thank you. So good afternoon, everybody. My name is Cindy Codispoti. Thank you, Beatrice, for that excellent introduction. I'm very happy to be with you here today to share some information about heart artery disease. And we decided to name it Keeping the Plumbing Clean to talk specifically about coronary artery disease, because cardiovascular disease has a wide range of disease processes within it. And I think most people want to know, how do I prevent my first heart attack? So we decided to focus on that today, but rather than talking about toilets and sinks, we're talking about matters of the heart today. That's our areas of expertise. So here are some of my objectives. First, I'll provide a brief historical perspective of cardiovascular disease, just briefly. Don't let the word history get you nervous. What is coronary disease? What is plaque? How do those pipes get clogged? We'll talk about prevention of coronary heart disease. In fact, that'll be the focus of the presentation. What factors lead up to plaque buildup and how do we slow down that process? And then we will discuss how to take charge of your own heart, what you can control and what you cannot control, but acknowledge. Finally, we'll focus on those factors that you can influence to help reduce your risk. So let's talk a little bit about history. Now, I'm not a history buff by any means, but this is kind of interesting information in my view. In the 1930s to 1950s, America knew infectious disease. That is what people were getting sick from and dying from. This is what the focus was on. But with the invention of penicillin, or the discovery of penicillin, in the late 1920s, 1930s, we started to get good hold of infectious diseases, and the ability to treat them improved landscapes. And so then started to mount cardiovascular disease instead. As we improved treatment of infectious diseases, we began to see more and more individuals become ill with heart disease. The problem was we knew very little about it, nor do we have any treatments available until about the 1950s, when aspirin became more commonly utilized, not just for pain control, but also for pain control within the realm of having a heart attack. So this is what heart attack looked like in the 1950s. You come in clutching your chest, and it was basically like, lay down, get some rest, here's an aspirin, and best of luck to you. And that's about all we had. So the evolution in treatment of cardiac disease, and specifically heart attack, from the 1950s to 2022 has been profound. Flash forward a little bit to the 1960s and all the way into the 2000s. They started a trial or a study in Framingham, Massachusetts, called the Framingham Heart Study. This study was the groundwork, the framework to help us understand a lot more about the process of cardiovascular disease and atherosclerosis, or plaque buildup. It was a paramount study that continues today. So it started with thousands of patients that they followed through the years to understand more about the disease process and to coin the term risk factors specifically for heart disease. We began to understand through the Framingham Heart Study what those risk factors were. And it's provided us a wealth of information. And even today, they are still studying the grandchildren and great-grandchildren of the original patients that were in this study. So then, as we began to understand more and treatments continue to develop and improve, flash forward to the 2000s, where now we have not only stents to open up blockages, but drug-eluting stents, which elute a medication to help keep the artery open even better than the original stents, et cetera, with wonderful medications that we have now to help reduce risk of heart attack and death from heart attack. And then as we began to become even smarter, we realized that treatment of heart artery disease is not the same for all, and that even though in the 1950s to 60s, we recognized it as a man's disease, we came to realize that it is also the #1 killer of women, okay? And that is for the last several years now. And then finally, I think the present focus is to understand more about diverse populations, because not all ethnicities have the same risk of heart disease. Some are at increased risk compared to others, and we're trying to learn a lot more about that. So that's just a little brief historical background about cardiovascular disease. So what is atherosclerosis? Basically, we're talking about the clogging of the pipes. And it's interesting that most of us, I think most of us on this presentation live in New Jersey, where the water is very hard. And typically you have to get soft water to protect your pipes. So we're going to talk a lot today about the stuff that clogs the pipes and why they get clogged and how to prevent the clog buildup, almost like investing in purchasing a water softener for your home, except it's your body, so it's even more important. So atherosclerosis is basically, it starts as the fatty buildup within the inner lining of the artery. And remember that the arteries are those pipes which carry blood flow and oxygen to the rest of your body. That's why the heart is so incredibly important. And in my opinion, the most important organ in the body. So that is what plaque is, and it starts off as fatty buildup. This plaque buildup can result in reduction of the amount of blood flow and delivery of oxygen to vital organs. It also causes the arteries to narrow down, to weaken, and to become stiff or less flexible. So this is a little picture depicting what plaque buildup in the heart arteries looks like. So on the left, you see what a normal artery looks like. And as you progress over to each picture from left to right, you'll see the beginning of cholesterol plaque buildup within the artery. And as it becomes more severe and advanced, it actually goes from a soft plaque to a hardened plaque, almost like scar, until its final stages where it becomes calcified and really, really hardened. Interestingly, we worry the most urgently about the soft plaque, which can actually ulcerate or become fractured, so to speak, and be sent downstream to cause a heart attack. Nevertheless, as the hardened plaque begins to grow and grow within the vessel, it can end up clogging the artery enough to not allow blood flow through as it should. You start to feel symptoms with exercise, and we'll get to that shortly. One of the things that this picture doesn't show, and was hard to find a picture that does show it, is the arteries are really interesting and intricate. By way of laws of physics, the artery can actually dilate a little bit to accommodate for plaque buildup. But by really, really specific laws of physics, it only can do that to a certain amount, and then it stops. And then the plaque starts to build up inside the vessel and clog the vessel artery, not allowing easy flow of blood to the heart, making it difficult for the heart to pump and do its job. So what is angina then? So what is this process called? What are the symptoms that we feel? Well, everybody knows the word angina. So let's talk about that for a second. All my patients like to say, I Googled this, I Googled that. I decided I was going to Google what is the best pronunciation of this word. So it turns out it is angina, actually, probably in Europe and in England, but the American form of the word is angina. So tomatoes, tomatoes, you could choose how you want to say it, but either is acceptable. Angina is chest discomfort or can be shortness of breath that is caused when the heart muscle receives insufficient oxygen-rich blood. So you're not getting enough oxygen to the heart as a muscle itself, causing usually some sort of chest discomfort, if not shortness of breath in some people, especially when you exert yourself. So this is a picture showing the heart arteries, okay? These are tiny little vessels, anywhere from about 1 millimeter to maybe 5 millimeters in diameter. So you can imagine how tiny those are. I have a lot of respect for our cardiothoracic surgeons who have to actually operate on these extremely small vessels. But these are the arteries that we're talking about that get clogged up with plaque and make it difficult for good flow of blood to the heart muscle to allow it to pump normally. So on the left, you see a picture of the heart with the heart arteries, and on the right, it's a blown up picture of one of those arteries with plaque inside of it. And you can see there's a fair amount of plaque in this vessel causing narrowing of the artery. What you can't see or appreciate is that artery also becomes stiff. The reason why that matters is it makes it difficult for blood flow to go through the vessel in an adequate amount. So I want to tell you a little story about, some of you may know me if I do have patients on here, and I know some of my staff are on here to support today. And I was in the Army for almost 25 years. And when I was active duty, I saw in consultation a 55-year-old lieutenant colonel, strong guy, healthy, in charge, in charge of a lot of soldiers, was doing great things, but came to me with some subtle symptoms, or at least he expressed them as being subtle. Every time he exercised, he felt a little discomfort in his chest. And when it got better, it went away, but I'm sure I'm fine. I don't think anything's wrong with me. I just have a little high cholesterol, nothing much else going on. So I said, you know what, look, you're in a high risk occupation here. We need to be aggressive and figure out what's going on. So we decided to, rather than do a stress test, go right to a cardiac CAT scan. Back in those days, especially, the cardiac CT angiography was becoming more and more popular. And I think, the military was on the forefront of using this modality to help look for blockages in heart arteries. We don't always jump to it because it does require a fair degree of radiation and also some contrast dye, which can affect your kidneys. So it has to be the right situation, and your suspicion for heart disease should be high. So anyway, with a clear kind of suspicion that this soldier had a blockage, I said, let's get you to a cardiac CAT scan. So this is a CAT scan, which is non-invasive, actually, requiring only an IV in the arm to inject contrast dye to be able to light up the vessels. So this is an artery, and I wish I had I'm not sure if you can see my pointer, but basically, let me go back one, I'm sorry. Well, I skipped ahead a minute, but apologize for that. So you could see there was a blockage up there on that CAT scan, okay? And it was very tight, probably over 90%. So we can't usually stop there. If we see that, we have to go further to a cardiac catheterization, which is the invasive form of looking for blockages and still accepted as the gold standard or the absolute way to rule in or out tight blockages of the heart arteries. So that's what you see right here is an angiogram. And at the top, you can see there's a tight blockage in the left anterior descending artery in the proximal portion, otherwise known as the widowmaker. So if this thing occluded completely, and as you can see, it's pretty close to that, you would lose the flow of blood all the way down that vessel, affecting approximately 40% of your heart muscle. This can cause severe symptoms, or even worse, arrhythmia that could lead to sudden cardiac arrest. So we were very lucky that we found it in this soldier. The good news is, and it was a good news story, is, right after the cardiac catheterization, he ended up with a stent to that vessel, which was seamless, and he did really, really great. And his heart function was preserved, and we had no problems from there. So these are two modalities that we use later on. For instance, if you have an abnormal stress test, or if your suspicion is very high, you can go right to these modalities to find if there's a blockage. So let's talk about some symptoms of heart attack. We discussed angina in the beginning, which can be somewhat of a warning sign for heart artery disease. But when it culminates in a heart attack, because sometimes you don't feel a thing until the heart attack, you can have a variety of symptoms. Most classically, it expresses itself as chest pain or pressure, maybe a heaviness, a squeezing in the chest, typically in the mid-sternal region. But it can radiate. It can go to the shoulders, to the left upper extremity or the left arm, to the right arm, to both arms, sometimes up into the neck or into the jaw. It may go to the back, the upper back typically. It can also cause shortness of breath. These symptoms can be concerning of heart attack, especially if it came on with a vengeance out of nowhere, got worse as you tried to move around or get your heart rate up, and perhaps improved when you rested. That said, if you're in the middle of a heart attack, it may not get better with rest, at which point you should activate emergency medical services by dialing 911. Other potential symptoms that may come along with these symptoms include extreme fatigue or feeling tired, associated dizziness or lightheadedness, feeling nauseated, maybe even vomiting, or developing a profuse cold sweat, or a sensation of anxiety or doom. These are symptoms that should prompt activation of emergency medical services. Don't ask your spouse or your friend to drive you to the hospital. That puts them in a really poor position, just in case something were to happen to you. We much rather err on the side of caution and call the ambulance, because that's what they're there for. So we talked a lot about the disease process and what you feel, but why is this so important to focus on prevention? And again, we only started really doing this in the last maybe 20 years through the American Heart Association campaigns and the American College of Cardiology. But it's extremely important, and this is why. The number one cause of death for both men and women in the United States and in Western Europe is heart disease. And that surpassed cancer many, many years ago. As you can see, I tried to get the most recent numbers that I could. So that in 2020, and think about what else was going on in 2020. We had a huge pandemic. Despite that, heart disease remained the number one killer of both men and women at 696,962. Interestingly, cancer is creeping up again. I remember doing these talks 10 years ago, and there was a big gap between heart disease and cancer, but it seems like cancer is creeping up as a number two cause of death in men and women at 602,350. Third to that was COVID-19, brand new as of 2020. Now we have COVID-19 as number three. So this is in part why it's so important to focus on prevention. So this data, we want to talk about why else focus on prevention. Okay, it causes death in a lot of people. In fact, going back many, many years, it was affecting over 385,000 deaths beginning years and years ago. And as of 2020, we're up to over 600,000. But in addition to that, as I alluded to before, over 50% of coronary deaths or heart attacks occur without ever having symptoms beforehand. And I know that's a scary number, and this isn't meant to scare you, but just to make you aware. And finally, if you're one of those people that say, well, I got to die of something, and we all have those patients too, and I understand, maybe you're fiscally sound or attuned to dollar signs and cost to the US government. Well, it costs the US government over $100 billion to treat cardiac disease each year. So it's profound. So what are our goals in coronary heart disease prevention? Well, I think we all kind of agree that the primary goal is to use research, evidence-based guidance to come up with tools to help us as providers assess you as patients in figuring out what your risks may be. Not everybody is at the same risk of heart disease, and we can't prevent all of it, but I think we can prevent a lot of it. And number two is we want to lower the burden of heart-related deaths, right? That's ultimately what we're trying to do is prevent unnecessary deaths. So informing patients is kind of a passion of mine and has been for many, many years. We are very lucky in cardiology to have large randomized controlled trials with thousands and thousands of patients that help us understand more about the disease process and what works to reduce your risk. So really working with your providers on identifying those risks is extremely important, and then addressing them. And I truly believe that the key to success is to intervene early, or in what we call the latent phase. The latent phase, otherwise known as when you have no symptoms, right? You're not feeling angina yet, but you recognize that you have a lot of risk factors for heart disease, and you start to address those. That is the key to success in preventing. So how do we do that? Well, you've heard risk factors throughout this talk already, and I'm sure you've talked about it with your primary providers, if not your cardiologists. How do we assess your risk as a patient of heart artery disease? We have come to terms with those that are known as classic risk factors, right? There's some classic ones. And I really regret that we're not together today, because I would love to go around the room and have people raise their hand. And I've done these talks before live and, with a different spin, but most people know, we're talking about diabetes, we're talking about obesity, high blood pressure, high cholesterol, sedentary state, and we'll review those again. These are classic risk factors that are well accepted for decades now. I like to split those up into two categories for my patients. There are those things that we can change and those that we cannot change. So here's another way to look at that. The things that we cannot change, we can call them non-modifiable. We can't change them. They're there with us. Can't change our age as much as we'd like to, and we try to. We're born with female or male genetics. We are either XY or XX. There are genetic factors built into our family, perhaps for generations, that we cannot change. Some of us would like to give our parents back, not me, but you can't change your parents. They are who they are, your race and ethnicity, that's who you are. You can't change those things. But as you can see, the list of things in green is a lot bigger than the list of things in black that we can affect to some degree. Those are high blood pressure, smoking, diabetes, physical inactivity, obesity, and high cholesterol. So let's talk a little bit about family history and genomics, or genes, what we can't change. Parents with a history of cardiovascular disease are close to you, and I would add also siblings. These are first-degree relatives, and if they had heart disease, especially at a younger age, so a male less than 55 years of age or a female less than 65 years of age, these are very significant risk factors for you. Yes, if your grandparents had them, or perhaps aunt and uncles had them, we also accept this as risk factors, perhaps not as strongly as a first-degree relative. Then other things can be partially inherited. We showed that high blood pressure, diabetes, and cholesterol we can affect with our behaviors, but there are also some genetics related to those as well. So you see patients who say, my mother, my sister, my aunt, we all have high blood pressure at an early age. There are definitely some genetics there, but there are things that we can do to influence them. Finally, it's interesting to me that about 75% of patients who have heart artery disease early, like an early heart attack, have a significant family history. So that emerges as a very strong risk factor. Let's talk a little bit about the role of inflammation in heart artery disease, because in recognizing that inflammation was important, we started to respect some novel risk factors of heart disease, such as rheumatoid arthritis. So in the 1990s, there is a physician named Paul Richter, who wrote tons of journal articles about inflammation and studied this. And I truly believe in it. I spent hours on this as a fellow, trying to understand the disease process a little bit beyond just high blood pressure and high cholesterol. And I think most of us agree that there is a strong role for inflammation in the body affecting the heart arteries and precipitating the buildup of plaque. So what inflammation does, as we understand it today, is that it can promote the growth of plaques. It can also loosen plaque in your heart arteries that's already pre-existing, and it can trigger the development of blood clots. And as you may or may not know, when you have plaque and a blood clot comes to try to heal that plaque, if it's big enough, it could occlude that vessel, spontaneously and abruptly, causing a heart attack. So now we see patients, and I really love to see these patients because it means that people in the primary care realm are paying attention, that autoimmune diseases such as lupus and rheumatoid arthritis, and excuse me 1 second, can cause inflammation within the body that can actually affect the heart arteries. And we're discussing things like lupus, rheumatoid arthritis, psoriatic arthritis. These are several of them. So actually, I have come to believe that, really treating these disease processes in these patients goes hand in hand with all the things that I can do in my office to help the patient lower risks of heart disease with respect to the classic risk factors. It's sort of a collaborative effort. Also foods, and I really love this topic. So my boys, who may or may not be on this talk today, we're always talking about foods that cause inflammation in the body, and I'm sure they're tired of hearing it. But basically, there are foods that cause inflammation, and they are the foods that are high in sugar content, that have high fructose corn syrup, that are fried. Even if you have a healthy food such as a fish, but you fry it, it puts that fish in a form that is unhealthy for you, or at least what's around the fish, whatever you're frying it in, that oil, it'll put it in a form that's not healthy for you. Refined carbohydrates and lacking fiber in your diet can increase inflammation and blood sugar. And what fiber does, and why it's important, is that it helps us process carbohydrates and fats and get rid of them. And then finally, too much alcohol. Too much alcohol can definitely cause inflammation in the body. And one might say, well, what about the Mediterranean diet? And it is true that, I want to say it was back in 2016, there was a very elegant study in one of our most prestigious journals about the Mediterranean diet, and really did show that if you adhered to a Mediterranean diet that happened to include red wine, that your risk of heart attack and stroke was way lower than someone that adhered to a low fat or low carbohydrate diet that we talk about in America especially. But the alcohol or red wine was not in excess. We're talking about up to 1 a day in a female and up to 2 a day in a male. Again, those recommendations, in my opinion, though, are not for everybody, right? So if there are people who have arrhythmias or other things that can be aggravated, so to speak, by alcohol, then maybe 2 a day in a male is too much for you, or 1 a day in a female is too much for you. So it's very patient specific. In any event, too much alcohol causes inflammation, and that should be acknowledged. So we talked a lot about the disease process, symptoms that can occur, some of the risk factors, and it sounds like such a profound problem and so heavy, but I really try to believe that I'm a glass half full kind of person. Let's look at the positive side. I think the positive side is that we know so much more today than we did 50 years ago, or back when we gave an aspirin for a heart attack, right? We are tremendously more knowledgeable. I do also appreciate we probably have more to learn. But while this is a big problem, the opportunity for prevention is vast. And a lot of it comes in educating each other, educating our patients. So let's acknowledge those risk factors we cannot change. They are what they are, right? It doesn't mean we have to lament over them or say, we're doomed. That's not necessarily the case. And I've seen people, let's say children of patients who have horrible heart disease, who adhere to very healthy behaviors, and they do well for years and decades, and maybe even their whole entire lives. Those are age, your family history, and genetics. Again, we cannot change those, right? But we acknowledge them. We bring those to the table at our physician appointments or provider appointments. We make our nurse practitioners and our doctors aware of what our family history is to the best of our ability. Some of us may not know. If you're adopted, okay. We move on and see what risk factors you have, and we go from there. But what about things that we can change? I really want to focus the rest of the talk on that. And I'm looking at the time because I do want to leave enough time for questions. But tobacco cessation, nutrition, activity and exercise, your weight, and lastly, emotional stress, which I really want to recognize at the end of the talk, especially in the last 2 years. So what are the effects of cigarette smoking on vascular health? This is really tough to get through to patients who smoke because it is an extremely addictive problem and very difficult to break. And I do understand that and respect it is tough, right? But maybe getting that picture of what cigarette smoking does to your body and kind of linking that in your mind can help one to sort of quit smoking or at least reduce the amount of smoking over time. So we know that it accelerates plaque buildup. That has been proven that cigarette smoke, perhaps because of both nicotine and tobacco, can accelerate plaque buildup. It can actually lead to an acute heart attack. It can shorten the exercise time to angina. So in other words, it doesn't take as long to walk before you start to get anginal symptoms if you're also smoking. It can cause spasming of your vessel, which is actually different than plaque, but the muscle itself can spasm as a side effect of tobacco and nicotine. It can cause stroke. It can cause weakening of the artery walls called aneurysm. It can cause plaque buildup in your legs or even your arms. If you have a stent in your heart, it can cause acute stent clotting or thrombosis. And then finally, if you have a graft from a prior bypass, it can occlude those grafts with clot. So these are the mechanisms by which smoke damages your cardiovascular system: by injuring the vessel, by damaging the inner lining of the vessel, which if not healthy, will not move well to move blood flow through it. It can increase your risk of clotting. It can cause inflammation, and it can reduce the delivery of oxygen to your muscles, and specifically your heart muscle. Let's move on to talk a little bit about diet. Such a confusing topic, and it's ever evolving, and I try to roll with it and roll with my patients because I can see how difficult it can be to keep up with what is the best diet possible. I want to start by saying you have to find individually the best, let's not call it diet, but the way of eating, a way of eating and nutrition that works for you. Okay, one of the things that's difficult to accept, even for myself, is that with each decade of life, according to the guidelines, the American College of Cardiology guidelines, this is where this is extracted from, 2021, is that with each decade of life, our need for calories decreases by about 70 to 100 per day with each decade of life. Okay, so something to keep in mind. We just don't need as much because our metabolism will slow down. They promote eating a diet rich in fruits and vegetables. And I know a lot of my diabetics say, well, I can't have a lot of fruits. There's a lot of debate about that. There are certainly some fruits that are less high in quick, simple sugars than others, maybe berries, for example, but work with your doctors individually to decide how appropriate fruit is for you. The other school of thought is if we're doing everything else right, we could probably, even as diabetics, eat whatever fruit we want to. So different schools of thought there, and the jury is still out. Again, individual decision making. Choosing whole grains instead of refined grains in my own house, right? Getting away from the white bread, which tastes better, to something that is whole grain is going to be much better for you because it's not as refined, therefore less inflammation, as we mentioned earlier. Finding healthy sources of protein. Currently, the way of thinking is that the more plants we eat, the better. And again, I individualize this with my patients. I have farmers that say, don't even tell me not to eat meat. And I get it. I get it. Some of us grew up on meats. The problem with the meats is who knows how they're processed these days compared to 50 or 100 years ago. So just keep that in mind and try to move toward healthier lean meats in smaller portion sizes if you really must have your meat. Otherwise, on the plant side of things, legumes, which is basically beans, and nuts are the best way to get good sources of protein. If you like fish and seafood, they really recommend eating, in the guidelines, 2 or more servings of fish meal per week, not fried though, okay? And then if you're going to eat dairy, low-fat, fat-free dairy products are going to be best for us. We already discussed meat. Try to avoid processed meats, sausages, hot dogs. I know I'm ruining the barbecues of the summer, but basically we have to stay away from those as much as possible. Also, if you're looking at oils and what oils to use, the guidelines recommend that we actually go toward plant oils. So avocado oil, extra virgin olive oil, which was used in the Mediterranean diet studies, and avoiding the tropical oils like coconut, palm, or palm kernel, certainly avoiding too much butter and margarine. Okay, these are hydrogenated or partially hydrogenated fats that are no good for us. You want to choose minimally processed foods. They've said minimally because they realize in this day and age, no one's going to get away from processed foods 100%. It's very, very difficult to do. So choose minimally processed, but as much fresh as possible. Minimize the intake of beverages. I feel like this is a really easy fix for a lot of patients that can decrease calories quickly. And that is your sodas, your juices, your teas, all of these things that can really don't necessarily hydrate you well like water will and have unnecessary added sugars or chemicals, right? If they're diet sodas, things like that. Finally, you want to choose and prepare your foods with little or no salt, especially if you're a patient with high blood pressure. And again, no more than 1 to 2 alcoholic beverages daily. But again, you may have other disease conditions where alcohol could be a problem for you. So work with your doctors closely on that. So whole foods, we see this everywhere. Whole foods that you can get on Amazon now, whole foods at the store. What does that really mean? We're talking about plant foods that are not processed or not refined in factories. And you want to eat as much of those as possible. So you want to spend the vast majority of your time in that aisle right there where all the fruits and vegetables are, and then go quickly through the rest of the store when you're shopping. So this is the American Heart Association and American Stroke Association's recommendation for exercise. I try to keep it simple for patients. I would say the majority of patients aren't doing vigorous exercise, and that's okay. You have to find an exercise that's going to work for you with any other musculoskeletal injuries or things that you may have going on. But in general, we want to do at least 30 minutes of moderate intensity aerobic exercise daily, 5 or more days per week, or at least 150 minutes per week. And let's face it, when you're especially middle age, height of your career, you may or may not have children, it's really difficult with your schedule. You may have a couple days where you can exercise very well and some not at all. And we do this in my own family. It's a struggle to exercise every day for my husband and I. Sometimes we have to, basically focus on the weekends to catch up as much as possible. And then if you're doing vigorous activity, basically you can get away perhaps with a little bit less, maybe 25 minutes a day, 3 or more days per week. This would be running or high intensity biking or CrossFit, things like that. So these are some general guidance. And I put this up there too, because you can visit theheart.org and look at patient information and exercise and diet. There's a lot of information on the websites about this. So here are some of examples of exercise. Moderate intensity, which I think most people do, would include things like brisk walking, water aerobics, dancing, gardening, tennis. If you're playing doubles, singles would be considered more vigorous, and then biking slower than 10 miles per hour. And one might say, why is dancing in purple, Dr. Codispoti? Because that's my personal favorite. More vigorous activities include hiking uphill, running, aerobic dancing, heavy yard work, tennis. So think about what you enjoy, what you can tolerate. The one thing I'm going to leave with you today on exercise, and I feel strongly about this, is that look at what you can do and not so much what your limitations are. There's really a strong mental piece there. You have to, excuse me, I come from the military, so I have had, the honor of working with soldiers and amputee soldiers and folks who've been through war, and finding a way for soldiers, because so many of them want to go back in the fight, let's say, is what I'm used to. So that's why I'm driven to help my patients understand, okay, you have really bad back problems, but can you use a pedal every day sitting there to get your heart rate up? Is there something that you can do with your arms, maybe a lightweight, high repetition exercise to get your heart rate up? This would still be considered somewhat aerobic. So there perhaps are ways for almost everybody out there, So working with your physicians to find out what's safe for you to do is a really, really good idea. Let's take a minute to talk about mental health. Mental health has emerged to me as such an important piece of coronary heart disease and heart disease risk, especially in the last 2 years, and I'm sure it's obvious why. The amount of anxiety and depression that I saw in my own practice, just anecdotally, and I know a lot of my colleagues agree, has been tremendous in the last 2 years, 3 years now, with being isolated in the beginning, especially, and everybody on quarantine and the fear of COVID-19 and how that affected us. And now we're seeing so many patients with emerging heart symptoms again, who maybe either didn't get them addressed during COVID or just have suffered so much from mental health purposes that are now experiencing cardiac symptoms. And addressing your mental health issues is extremely important, and really removing that stigma that it's, you don't want to address it is so important to me as a physician. Depression, anxiety, stress, post-traumatic stress disorder over long periods of time have been proven to show physiologic changes in the body that can put you at increased risk for heart disease. And what it does is it increases cardiac reactivity, i.e., it leads to higher blood pressure, higher heart rates, intermittent surges in your blood pressure, and all of these can affect you over time. And when this happens, you can reduce blood flow to the heart muscle, over time, causing some risk for heart attack. Finally, what stress does to the body is increase a hormone called cortisol, and cortisol can lead to weight gain, and weight gain can lead to higher heart attack risk. So you can see that there's a lot going on with respect to mental stress and how it affects your heart specifically. So, we talk a lot about reducing stress. I might add in there maybe managing stress is the better way to think about it. We're all going to experience stressors in our lives: loss of loved ones, diseases, taking care of elderly, taking care of spouses, children, work-related, you name it, they're out there, and they'll fluctuate throughout our lives. How we manage those stressors in our lives will directly affect our physiological health, and specifically heart health in this discussion. So working with your providers, talking to a psychologist, talking with your friends, going out and connecting with nature. These are all things I try to emphasize with my patients, because I think that it can help you reduce stress, and you don't have to bear that brunt by yourself. Let's talk a little bit about weight, such a sensitive subject for so many, I know, but it's important because there is an obesity epidemic in our country, and maybe the greater world, especially the modernized world, the Western world. And so this is just a really, I think, a neat graph to show that you'll see the sweet spot for decreasing risk of death from anything, actually, is having a body mass index. So that's basically your weight in relationship to your height. A body mass index between approximately 20 and 25, just to keep it simple for patients, is where you want to be. The vast majority of people are not there. We really have an obesity epidemic in our country, and it needs to be addressed because it really is increasing risk of heart artery disease, but not only that, arrhythmias and a lot of other heart problems such as heart failure. So you can see your risk of death goes up significantly when your body mass index is greater than 35, and look what happens over about 40. It's 100% higher than if your body mass index were only 20 to 25. Just an interesting little bar graph here from the National Health and Nutrition Examination Survey that they put out to patients. This is from the government putting out a survey to patients or people, civilians, in 2013 to 2016, showing what those people do to try to lose weight. And most people, the top three would be exercise, eating less, and eat more fruits and vegetables or salads. These seem to work best. Fourth to that would be drinking a lot of water. But really, it's a mixture of all these things that are going to help you. And sometimes making small changes rather than doing something completely drastic is going to be more sustaining for you to keep weight off or lose weight. So these partially inherited risk factors that can be influenced that we talked about earlier, I just wanted to note them, and that is high blood pressure, high cholesterol, and diabetes. A lot of folks say, well, it runs in my family, which may be true, but a lot of the things that I showed you, weight loss, changing your diet, and exercise, can also influence these three things significantly. So you do have some control over them, and I just wanted to point that out. This is just a graph showing what is considered high blood pressure in 2022. So a couple of years ago, the guidelines changed again. Why? Not because pharmaceuticals want to make more money. It's because the research shows that when your blood pressure is higher than 130 systolic or 80 to 89 diastolic, you start to develop increased risk of heart disease. So these are the new parameters here of what is normal. And it's respected that a systolic blood pressure less than 20 and diastolic less than 80 is actually a normal blood pressure. So these are, I encourage a lot of my patients, if there's a question of whether their blood pressure is a little bit elevated or it's just white coat hypertension, meaning when you go to the doctor, it rises because you're anxious about that. Maybe monitoring at home is the best way to get a better feel for what your average blood pressure is. And it's your average resting blood pressure that you're treating. And these are some interesting hints when you measure your blood pressure at home to look at that comes right out of the American Medical Association. Things like don't talk about finances with your spouse, empty your bladder before you check your blood pressure, make sure you're resting, feet flat on the floor, a bunch of different things. So I encourage you to look that up if you're interested in monitoring a good blood pressure at home and getting some really accurate numbers to share with your providers. And then what about cholesterol? Cholesterol is very well respected as being a contributing factor to plaque buildup in your heart arteries or any vessels, arteries, and can be inherited, but can be influenced by our behaviors. So you want to really understand what your cholesterol is. Now we're even looking at pediatrics. I sit on a lipid work group with both cardiologists and primary care and pediatrics, because we realize, especially with the obesity epidemic, how important it is to recognize what cholesterol levels are even in children. And if it's identified as being familial or passed down through genetics, maybe treating a lot earlier so that those young individuals, those children, won't have a heart attack when they're 40 or 45 years of age. So it's important to know what they are, to monitor them, and to work on them in a natural way as much as possible. Then when you need help and when the guidelines suggest it's appropriate, in discussion with your providers, to then get it treated. And the first line treatment remains statin therapy. So I encourage you today to take all of this and digest it and take your heart into your own hands. Your heart really belongs to you. You have the power to be healthy, to change your lifestyle in a way to help protect you so you live your later years in a healthy way and enjoy them. You want to, this comes from the American Heart Association, the heart.org. You can look it up online if you'd like to, encouraging you to take charge of your own heart. So this is from the Go Red campaign, which recognized heart disease as the #1 killer in women, starting back in the, I want to say in the early 2000s is when that campaign developed. But it really applies to all patients, all individuals. Go Red. So G for get your numbers, understand what your blood pressure is and your cholesterol, be aware of them, work with your doctors to find out if they need to be treated. Own your own lifestyle. So quit those behaviors that accelerate plaque buildup, smoking, unhealthy eating, lack of exercise or sedentary state. Realize what your risks are. Remember, we talked about acknowledging those risk factors that we can't change. So knowing what your family history is to the best of your ability. And if you think it won't happen to you, understand that heart disease kills approximately 1 in 3 women and 1 in 4 men, which is really a profound number. The E is to educate your family. And I'm sure my boys and my husband are tired of hearing it, but can't help it. It's your passion. You have to bring it to your family, right? But do share it with your family, help them to do better and understand more about the disease process and how it may run in your own family. And finally, the D is don't be silent. Share it with women men that people that you're concerned about. And then finally, I just wanted to show a couple pictures of my amazing team at AMG Cardiology in Hackettstown and now in Sparta. We recently in May opened up a practice in Sparta. I am missing, I think, just one individual in these pictures, which is Olga Pierce. Olga, I'm sorry, we'll get you in the next picture, I promise. But on the left is some of my teammates. One of them is gone, but we have everybody is just phenomenal in taking care of patients, and I want to thank them for their support. And then on the right is our opening day at Sparta. So that's where I am today. And we have a wonderful team of people here to take care of our patients, and I'm forever grateful to them. And then last but not least, I want to thank my family, who unfortunately I tried multiple times to put a picture on here this morning and it didn't work out. But my family, my job is my passion, my family are my heart and soul. So just want to thank Matt and my kids for all their support. And thank all of you for joining me today on this talk. And I hope you learned just a little something to help you take care of your own heart. And I'm happy to answer any questions.
Thank you so much, Dr. Codispoti. That was an amazing presentation. We do have a couple questions, so we're going to try to get through most of them.
Sure.
Our first question is, can statins dissolve or eliminate plaque buildup already in the LAD, or do they only prevent further accumulation of plaque?
Yeah, that's a really great question, actually. There are some research trials out there that show that statins may regress plaque a little bit, and that above and beyond reducing LDL cholesterol, they can actually reduce inflammation, which is why we push so hard for them in high dose. If a patient walks in with a heart attack, it's actually in the guidelines to put them on the highest dose. You know that it's not going to reduce the LDL so quickly. So why does it reduce the risk of heart attack or death from heart attack by adding a statin in high dose the night that a patient comes in with a heart attack? We truly believe that it stabilizes the plaque and reduces inflammation. But long term, can it decrease the soft plaque in your heart arteries? I think there is some data for that to a minimal amount. But hardened plaque is a little bit more difficult to overcome because it's been there for a while and it's more stabilized. So I hope that answers the question.
Thank you. Did the CDA just announce a new position on statins? Are statins, I believe they might want to ask, do statins have adverse long-term issues?
Okay, so can you repeat the first part of the question?
Did the CDA just announce a new position on statins?
Oh. Okay, yeah. So, we have to keep up with all this. There's no doubt that there are some very well-established side effects with statin therapy. And long-term side effects are still in question, I believe. There's a lot of back and forth in the data about causing some fogginess in the mind or accelerating dementia. But the problem is that we also have data showing that if you don't reduce plaque buildup in the arteries that even affect the brain, that vascular dementia is precipitated. So it's really, I think the jury is still out there, and I don't know 100% yet. So again, this is a very individual decision with your patients, and the way I approach it is to treat patients per the guidelines if it works for them and in discussion with them, but then also appreciate the long-term risk. So maybe by the time you're 85 or 90 and you haven't had a heart attack and you're not high risk, but you've been on statins for years, you may make an informed decision with your doctor. Do I really need this anymore? So I think we still don't have black and white answers on that, but so far the data in support of statin to reduce risk of heart attack and death from heart attack still outweighs any potential long-term risks.
Thank you. We have a comment. My stress test indicated no blockages, but my calcium heart scan showed plaque in the LAD, and my score was 240, putting me in the 80% range to have a heart attack. I am a female, walk 3 miles a day, exercise, and I'm 80 years old. I have trouble taking statins as they all have given me muscle discomfort and weakness. So I guess their question would be, what would you recommend for that?
Yeah. So, okay, but I was sitting with you personally, whoever the patient is that asked that, a couple of things. First of all, if you remember the pictures of the arteries that were open and that plaque builds up, and then it's not until the plaque gets really big and occludes the vessel that starts to cause symptoms, right? So what that tells me, the information that I'm given, is that the stress test shows that there's enough blood flow getting to your heart despite the amount of plaque in that heart artery. So you may have a heavy burden of plaque buildup, which, by the way, some of that is a normal process of aging, but it's not yet affecting the flow of blood in your heart. That's kind of what that tells me with the information, the limited information I'm given. And I think that's a good sign. So now the doctor's probably saying, let's reduce your risk by keeping you on a statin therapy that also stabilize the plaque that's in there. There are alternatives to statins if you can't tolerate them and you have a high risk calcium score that you may want to talk to your doctors about. One of them is an injectable medication, which sounds scary, but I have some of my most stubborn patients about medications on them, and they're doing phenomenally. So I really, and I tell them that I tell this story, so I don't feel bad about calling them stubborn. But the bottom line is that it really is not a difficult injection, and it's only every 14 days. So that's one class of medications you can look at. And then there's another one that's an injection that's only twice a year. That's a bit different. The data out on them are different. One's newer than the other, but you may go back and ask your doctors about the injectable forms of the lipid lowering medication. I just want to also point out, I think you said that it was 80% risk of having a heart attack. Next time you see your physician who did that score, clarify that, because what that percentage usually means is not 80% risk of having a heart attack, but that if you took 100 women within 5 years of your age, you would fall at the 80th percentile, meaning that 79 women who are around the same age as you, if we randomly did a calcium score, would have less plaque, and the other 20% would have more plaque. That's usually what that 80th percentile means, not that you're at 80% risk of having a heart attack in the next 10 years. Now, that said, if you're at the 80th percentile, it is elevated risk of having a heart attack in the next 10 years. So it's a little bit, there's a lot of nuances there, and something that's, very individualized. So I hope that answers that question, but there are alternatives for statins out there that you should ask about.
Thank you.
Sure.
We do have multiple questions, but we are limited on time, so I'll take maybe 3 more questions. Can the amount of plaque be reversed through diet and exercise?
That is a great question. Yes. So again, there are some studies showing some minimal plaque regression or reduction with heart healthy diets, especially. And you see this most in the vegan diet. So I didn't push the vegan diet a lot today, mostly out of time, but also because so many patients just say, I'm never going to do it. But really extreme plant-based diets can regress plaque a little bit, and it's really up to you. There are patients out there that just do it. And, I think it will be helpful for them long-term, but I guess the more plants we eat, the better off we are, and the better chance we have at having that happen.
Can you talk a little bit about stroke and how it's related to the plumbing?
Oh, okay. That is a great question. Stroke is different. We think of stroke as a brain attack, but the disease process is similar, right? So a stroke is caused, some strokes are caused by plaque buildup in the vessels of the brain, rather than plaque buildup in the vessels of the arteries of the heart. So the way that they're related is that the disease process of plaque buildup, as we discussed earlier, atherosclerosis, is very similar and treated about the same in terms of medications, diet, exercise, eating the right things, controlling blood pressure and cholesterol. So that is how they're related. There's a different kind of stroke that can be triggered by clot formation that can happen in the heart. And I think that's where there's a lot of mix up, is because they say, heart disease causes stroke. It's usually from a clot that can build up, specifically from, for example, atrial fibrillation. That's a different type of stroke. But the ischemic stroke, which is lack of blood flow and oxygen to the brain, is basically like a heart attack, but it's a brain attack caused by a similar disease process.
Thank you.
Sure.
We'll take 1 more question just to respect your time as well.
Only because I have patients starting at 1.
Exactly. Is there a test to see if you have a high cortisol level?
I'm sorry, say that one more time.
Is there a test to see if you have a high cortisol level?
Yeah, there are blood tests to check for high cortisol levels. I don't know of many cardiologists that do that. Because it can fluctuate significantly. That would be something that maybe an endocrinologist would do if they're concerned about abnormal cortisol production because of an organ dysfunction in your body. But I don't know that there's a role yet, to be honest, for random cortisol checks, because they can fluctuate with so many different things each day. Definitely not my area of expertise, but it's not something that we routinely check within the realm of cardiology. If you're stressed, your cortisol level is going to go up, so there's just, but I think if there was a medical suspicion for overproduction of cortisol or something like that, then an endocrinologist, for example, would be checking those levels.
Perfect. Well, that is all the questions we can take for the allotted time, but there is a lot of thank yous to you, Dr. Codispoti.
Thank you so
Greatest
much.
fan. I believe one of your children are on. They said thanks. Very informative. Love you.
Thank you, Brother John.
And I think we are set for the day. We want to respect your time as well, as you do have patients starting soon. So everyone, thank you for joining us. We appreciate your participation and feedback. Please take a few minutes to fill out today's survey that will be sent out to you and was also added onto the chat. A special thank you to Dr. Codispoti for dedicating your time and expertise today. If anyone
Thank
has,
you so much. I enjoyed it. Thank you. I'd love to
thank
see you in
you.
person someday.
I am looking forward to your in-person as well. If you have any additional questions or comments, please send us an email at communityhealth@atlantichealth.org or call us at 1-844-472-8499. That concludes our webinar. Thank you, everyone, and have a great rest of your day.